Welcome to SkinSync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Welcome, everybody. We're here with special conference coverage at RAPIDS 2026 in Fort Lauderdale, Florida. I'm Eileen Cheever, and I'm honored to be here today with Dr. Singla. Welcome.
Thank you for having me here.
We're happy to have you on our SkinSync podcast and review some of the amazing lectures that you gave today. So let's start with that first lecture that looked at that interdisciplinary approach to the management of patients with psoriasis and psoriatic arthritis. You had highlighted the pre-PSA phase. What are some of those subtle clues derm providers should be looking for?
Yeah, this is an interesting phase in patients' lives when they're developing early symptoms of psoriatic arthritis. Some of the clues are based on the disease manifestations. When the patients complain about joint pain, the first thing that you should be asking the patient is the duration. Is it acute onset versus a chronic onset of pain? Because that can help you differentiate between an acute inflammatory condition versus chronic inflammatory condition. The other subtle clues are about the history of the pain. Does the pain get worse with physical activity or better with activity? Is the pain worse in the morning or worse in the evening? How does the pain changes with activity? Does it become more severe or improve with activity? So these are some of the subtle clues that will help you understand if the patient has inflammatory joint pain versus non-inflammatory joint pain.
So listening to that history is really key.
Yes.
And if you pick up on some of those subtle clues that the patients provide, you may transition to diagnostics. Can you touch on the role of ultrasound and MRI for psoriatic arthritis diagnosis?
Yeah, ultrasound and MRI are not used for diagnosis of psoriatic arthritis. Diagnosis is based on clinical evaluation, but these are helpful tools if you're not sure clinically if our patients have psoriatic arthritis. Help us figure out if or can confirm our findings. Ultrasound is user dependent, so it depends on how much time you have, how many joints can you take a look. But the studies have shown that the both tools, both ultrasound and MRI, are helpful tools in evaluating inflammatory arthritis of the joints.
And that's interesting because there can be a lot of subtle nuance with that, and it's not necessarily all or nothing with that. I think we'd all love to work with or be associated with a combined clinic, really focusing on that interdisciplinary care, but easier said than done. How about some practical barriers to building those combined clinics? And how have you seen some of those successfully overcome?
Yeah, there are lots of barriers, right? First of all, can you make a dermatologist and rheumatologist get along and have a, um, a particular medication? Come up with one medication, right? Dermatologists favor IL-23 inhibitors, and a lot of rheumatologists don't like IL-23 inhibitors. So they're starting from just the data that we have, starting from the evidence that we have for the treatment of both the diseases to nuances of everyday running clinic, right? How many patients can we see in one day? Dermatologists typically see a way more patients in shorter duration of time as compared to rheumatologists. I can give you an example how we overcame this issue in our clinic is when our dermatologist sees way more psoriasis patients than I see psoriatic arthritis. So he goes and sees the patients first, and then he comes, asks them if they have joint pain, and then I go inside the room and in when I am examining my patient inside the room, he in the meantime can see 2 or 3 more patients by the time I come back, and he and I discuss the treatment together. The time is a barrier, and also rooms is sometimes a barrier. At least in our academic center, we have enough rooms where a dermatology clinic can dedicate a room for me to spend time in and examine the patients. But those are some of the issues that we need to be looking at while establishing these combined clinics.
If we're not in those combined clinics, what are just some general realistic ways to improve collaboration? Again, if we're not in that setting, but we'd like to collaborate with somebody like yourself.
Yeah, I think some of the things that can be done on outreach programs, at least I can talk for rheumatologists, they can go and advertise at a dermatology office that they're there for the patients. It can be easy access should be available. dermatologists should be able to either do maybe a virtual clinic, a virtual Zoom meeting with a rheumatologist and try and understand if the disease, even if they're not sure what treatment to give, at least have a conversation with a rheumatologist would be helpful.
And now, talking about your other lecture from your point of view as a rheumatologist and getting that referral in your inbox or on your desk, what does that ideal referral look like from your perspective? And can you give us any helpful tips or tricks about when to refer to rheumatology?
Interesting question. So, the ideal referral is when the question is very specific. For example, here's a patient whose skin is well controlled with a medication, one particular biologic, but it's still having heel pain or Achilles tendon pain. Do you think this is due to wear and tear arthritis or it is due to psoriatic arthritis? So, that's an ideal referral, but it is sometimes hard to have those specific questions. Good referral, if a dermatologist can do a full examination, which is hard, I can understand, but at least know if there is effusion, active effusion in the joints, and know what kind of history does the patient has. Are they favoring more of inflammatory joint pain versus non-inflammatory joint pain would be helpful. And there is no need to do a lot of blood work or to rule out other diseases if you're sure that the patient has inflammatory psoriatic arthritis.
And you did touch upon in what you just said, those exam techniques. You really walked through some really helpful exam techniques. What are some of the most underutilized physical exam maneuvers that we can incorporate in our exam when we're in our dermatology clinics?
Yeah, something very simple, like we discussed in the lecture today, is looking for joint effusions. We discussed how you can look for synovitis of your hand joints, metacarpopharyngeal joints, proximal interpharyngeal, and distal interpharyngeal joints. A couple of other tests that are useful is enthesitis test, looking for lateral epicondylitis or medial epicondylitis, just examining the Achilles tendon insertion on the heel or looking for this retrocalcaneal bursa enlargement. So these are basic physical exam techniques that we discussed during today's lecture that can be done very quickly in a dermatology clinic.
And I think even when we have integrated some of those physical exam maneuvers in our clinics, for those of us that have, I think the patients are shocked to hear a provider who works in an office that does skin is actually putting their hands on the joints. And sometimes they're quite surprised. They might even inquire why. And it can really enhance their confidence or that buy into that collaboration. And they love that you're really putting your hands on them, maybe even outside something like the skin. So let's talk about the CASPAR criteria. It's wide in its breadth, but it would be really helpful if we could review that CASPAR criteria for our listeners and just review that from a high level.
Yeah. CASPAR criteria is the diagnostic, well, let's say classification criteria for psoriatic arthritis. We don't use this criteria for diagnosing patients in everyday clinic. This is mostly used for research. But I'll go over a few points. These some points to be considered are if the patients have skin psoriasis. Active skin psoriasis gives you more points over just history of skin psoriasis, and even family history of skin psoriasis matters. Nail disease, active nail lesions, pitting in the nails, onycholysis, all of these are important points. And dactylitis. Dactylitis is where the whole finger or toe becomes really swollen. That gives you a point. And there's a special point for a negative rheumatoid factor in this criteria. And some bony changes that you can see in psoriatic arthritis are also part of this criteria. So patients who have this positive criteria can actually classify for psoriatic arthritis clinical trials.
You'd mentioned a point for a negative rheumatoid factor. Let's talk about lab work. There's often some confusion around lab work. Should I try to help that rheumatology consult or referral by getting some of that lab work? What should dermatology providers order versus just really deferring to your expertise?
At least as far as I'm concerned, I don't think I need any labs from dermatology, especially no ANAs. But it is a clinical diagnosis. The patients need to be examined. They need to be asked questions. They need to be heard. That is what is important. I don't expect my dermatologist to run any labs or imaging before sending the patients to me.
That's helpful. That makes it
Yeah.
easy and less overwhelming. And lastly, what are some points to consider if skin is well controlled on one biologic agent, but the joint symptoms are worsening?
The question is if the joint symptoms are worsening or if the patients truly have inflammatory arthritis. Some of the points to be considered is to make sure the joint symptoms are not due to any other diseases like osteoarthritis or fibromyalgia or for that matter gout. Those things are important and that can be evaluated by rheumatology. But if you're pretty sure that the patient has psoriatic arthritis, it'll be, if you're trying to think about changing the therapy, it'll be important to know if there is axial involvement because there are some drugs that can be used in axial disease have shown efficacy as more in axial disease as compared to others. Also, some of the other factors such as IBD need to be considered, comorbidities need to be considered before changing therapy.
And last but not least, you were really gracious to share one of your cases during our complex cases panel. And you had described a 51-year-old woman with a 7-year history of psoriatic arthritis. By the time they had seen you, had been to 2 different rheumatology providers, had that kind of ongoing joint pain, some dactylitis, some limitations functionally, with a normal CRP, ESR, with really not much inflammation going on the ultrasound. And I was so curious when you were describing this case, you had asked a question about her true diagnosis. Really, what was the real kind of etiology at play? And the bridge to a conversation about, intervention and what some of the treatments she had cycled through prior to seeing you. Can you take us through this case?
Yeah, so I've also presented this case for difficult to treat guidelines. So was a 51-year-old female with 7-year history of psoriatic arthritis. She's seen many other rheumatologists because of ongoing joint pain and functional limitation. She had no evidence of inflammation on ultrasound, and her inflammatory markers were normal as well. So there was a cycling and rotation of different physicians that she saw, but she could not get answers of what was going on with her. In these kind of cases, we truly have to assess is the disease is treatment refractory or there are some other factors contributing to this difficult to treat PSA case. And, we need to evaluate if the patients are in pain due to other issues such as fibromyalgia, osteoarthritis, and maybe this patient did have PSA in the past. She did have evidence of dactylitis, well documented evidence of dactylitis. Maybe now it's treated because she's already on biologics. So was early intervention with biologics helped her psoriatic arthritis much earlier, but she continued to have this lingering pain, and it is important to establish the diagnosis of why she's having pain.
And what did you end up doing for the patient? I'm curious.
This patient actually had fibromyalgia,
Okay.
and we put her in a therapy class where she saw a physical therapist regularly, and she actually improved after some cognitive behavioral therapy and physical therapy. Yeah.
Interesting end to that case. Well, from sharing cases to letting us know what's ideal in the referral, we want to say thanks for joining us here at special conference coverage for Rapids 2026. Thank you.
Thank you for having me.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.